Good afternoon, everybody. For those of you who don't know me, I'm Tina Lavender, and I'm Professor of Midwifery at the University of Manchester in the UK. And I'm delighted to be here and to be chairing this session. I'm sure it's going to be a very exciting session and something that really resonates with midwives. Before I go through the housekeeping, as usual, just like to declare any disclosures related to any relationships with Johnson & Johnson, which you can see here on the slide. So you've all been given a keypad. If you haven't been given a keypad, please raise your hand and one of the staff will make sure that they bring one to you. And the keypad is so that we can have a little bit of fun, but with some questions and answers. The question will be displayed on the screen, and then you will have 10 seconds to make your choice. So we will give you multiple choice of answers. Press the button representing your choice, and then if you decide to change your mind, all you need to do is pick another number. If you decide that you don't want to vote, that's fine too. You can abstain. It's not compulsory. But please make sure you return your keypads at the end of the symposium to one of the staff on the way out. So we're going to have a little bit of a practice of the keypads. So let's ask this question. What is the heaviest live birth ever recorded? So question one, 15 pound 8 ounces, which is 7 kilos. Answer 2 is 19 pound 3 ounces, or 8.7 kilos. And answer 3, 23 pound and 12 ounces, or 10.8 kilos. So you have 10 seconds now to press your button and give the answer that you think. Okay, so you should have all pressed your choice by now. And you can see here what you've decided. So most of you believe that it's fairly heavy, 23 pound, 12 ounces. So, and you were right as well. Well done. Obviously a very clever audience. Please be aware that some of the questions, there isn't actually a right answer. It could just be that we're asking for your opinion. So there's not necessarily going to be a right or wrong answer. So this session is all about touch. And touch is intuitively an aspect of a midwife's role. And why is it important? Well, touch is fundamental. It's the first sense to develop in the uterus. Touch is required for healthy development. Developmental delay is often seen in children receiving inadequate or inappropriate sensory stimulation. And touch is universal in all parts of the world. We can certainly learn from developing countries how to incorporate touch into everyday routines to help promote healthy skin and infant development. So today, I'm really happy that we have 3 excellent speakers. We have Professor Michael Leon from the University of California, Professor Martha Pele from the University of Miami, and Pandora Hartman, Human Resources for Health Rwanda, University of Illinois, Chicago. The full biographies for these speakers are all in your booklets, so I'm not going to read them all out to you, but I'm delighted to introduce our first speaker here, Professor Michael Leon.
Thank you, Tina. All right, let's see if this works. Okay, when you look around the world and look at traditional societies, there's a great deal of touch, tactile stimulation, and olfactory stimulation that happens concurrently. And when you look at the amount of time that they spend in contact with their young, it's enormous. And that's particularly compared to people in the Western world, where touch is very little and olfaction is very rarely stimulated. And it turns out that if you look at the probability of having autism in the developing countries, it's actually very low. And it's not just a reporting artifact. If you go house to house, you can see that autism is very low there, whereas children raised in the Western world turn out to have relatively high levels of autism. And so one question that you might ask is whether this correlation actually has something behind it. That is it possible that the low levels of olfaction and tactile stimulation actually make individuals more susceptible to the expression of autistic symptoms? Well, an unfortunate experiment was done in Romania where children were, in large numbers, were left in orphanages. And they were left in orphanages, they were kept healthy, but they were given very little sensory stimulation, very little stimulation of any kind. And it turned out that 1/3 of these individuals developed what is called post-institutional autistic syndrome, which means they developed the symptoms of autism 33%. It's an extraordinary number. And what that means, perhaps, is that the loss of the sensory stimulation seems to have increased the probability of the expression of autistic symptoms. Really interesting is that at a certain point, they took these kids and gave them to foster parents. And when they did that, most of their symptoms disappeared, right? So when you decrease sensory stimulation, you increase the probability of autistic symptoms. And when you increase sensory stimulation, you decrease the probability of autistic symptoms. And so we thought it might be an idea to take children with autism and increase the amount of sensory stimulation that they received. We're particularly interested in using olfactory and tactile stimulation because the work from our lab and other labs have shown that olfactory and tactile stimulation seems to have a particularly sensitive entry into the developing brain. And there we go. So if you pair olfactory stimulation with tactile stimulation on the first day of life, the infants become attracted to that odor, and that's how they become attracted to the mother's odor. And eventually that odor comes to calm them. It calms them when they're feeling distressed. So it's a really important olfactory learning that goes on, even on the first day of life. And so we thought that this kind of stimulation would be critical for the increase in sensory stimulation that we were going to give. Okay, and so we developed what we call sensory enrichment therapy. And what we did was give them olfactory stimulation, different odors, 4 times a day in the presence of a light massage on their back. And we gave them olfactory stimulation through the night by putting a bit of odor on their pillow. And then morning and night, we tried to stimulate all of their senses. So we had olfactory and other kinds of sensory stimulation games that we changed. We had about 3 dozen of these, and we changed them every 2 weeks over the course of 6 months. We looked at children 3 years old to 12 years old with classic autism. That is, they were seriously affected individuals. And these were the fragrances that we used. These fragrances have no special meaning except that I like them. So that's why we use them. And here is a question. If you ask people from different cultures which of these odors they like, which one would you choose? Orange, grapefruit, bergamot is a very light orange odor, lime or peppermint. I know which one I like. What do you like? Go. Okay, and the answers are orange, not even close. The answer is lime. Yeah, surprised me too. So if you ask mothers what their favorite odor is, all right, it's the odor of their child. And in fact, if you ask women regardless of their being mothers or not, what their favorite odor is. It's the odor of an infant. And if you ask American men what their favorite odor is, what do you think it is? It's the odor of frying bacon in the morning. Okay, so we did this study. Remember, we tested them before and after 6 months. And we first looked at their cognitive abilities. So here's, after 6 months, they actually had an enormous bump in their cognitive abilities. The difference was over 11 points on the cognitive scale. This is a scale that's used to calculate their IQ. We also asked whether there was a big change in their autistic symptoms. And in fact, there was. What we did was say if you had at least a 5-point jump in your childhood autism rating scale numbers, we would consider that a big improvement. And 42% of the children who are in the sensory enrichment group had that kind of big jump, while only 7% of the kids who are getting standard care. Now, standard care is not just sitting in a closet. They were getting 30 to 40 hours of one-on-one treatment every week. So they were getting speech therapy, physical therapy, reward therapy for appropriate behaviors, and still they did not make the big jump in their symptoms that the children with sensory enrichment therapy did. All right, so here's a child on her 3rd birthday with classic autism.
Prague, what do you got there? Christina? This is the way Christina feels in the mornings, even on her birthday.
So you can hear in the father's tone of voice that this is not a novel situation. And in fact, one of the core problems in autism is problems with language. So this is a girl who's 3 years old. She only had 3 or 4 words available to her. Here she is a year after she initiated sensory enrichment therapy.
Hey, Mommy.
Yes.
Do you know I draw wonderful things?
I know you will draw wonderful things. I love your pictures.
It's a story, just like a trumpet with just one piece of paper.
Ah. Do you like drawing stories?
Yep.
That's great. What's this story about?
It's about Save the Day.
Save the day?
Look, there's me.
Okay.
Now, let me find that white.
Okay. Another core symptom of autism is problems with social interactions. Here's a boy, 6.5 years old, who has obvious, profound social problems in our study.
Hi, nice to meet you. My name's Dr. Han. Can you shake my hand? Oh, okay. Do you know what we're going to do today? No? I'm gonna ask you some questions. We're gonna do some puzzles and some games, okay? Are you scared? It shouldn't be too scary. Let me show you what we're gonna do, okay?
So you can see by the expression on this mother's face that this is not an unusual circumstance. Here he is 6 months later.
Silly.
How about this?
It's a penguin.
These?
Those aren't bugs.
How about these?
A starfish. Those are some clothes.
Good.
That's a tire. That is a big bridge.
Good. I like your descriptions.
Hey, look, there's one more picture.
What are these?
These must be suitcases.
Okay, so we did a second clinical trial with more subjects in it, and what we found was pretty much the same thing, and we also were able to extend our conclusions. Here's the IQ score after 6 months. It's over an 8-point gain in IQ compared to about over a point for those in standard care. When we looked at their sensory profile, what we also found is a dramatic improvement. Over 90% of children with autism have problems with sensory interactions. They either seek out sensory stimulation or they have an adverse response to all kinds of sensory stimuli. And what we found is that there was a profound improvement along those lines. As I mentioned, languages is also a key core problem for children with autism, and what we found is that their ability to understand language improved by 212%, and that's very good compared to the 14% improvement that we see in children in standard care. Then we decided to ask the most difficult question, that is, could we actually change the diagnosis of these children? And so what we did was use the gold standard measure of autism. It's called the ADAS. And what that did was show us the proportion of children who are no longer considered to be autistic. And what we found is that 21% of the children improved to that level. That's something that's not heard of with standard care. And you can see 0% of these children had that improvement in standard care. Here's a child who has the third core problem in autism, that is having repetitive idiosyncratic behaviors. You can see him at the start of the trial.
So what's going on in this picture?
They're cooking.
What else is happening in this picture?
Cooking.
What else?
Cooking.
And tell me about this picture.
Raining, 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 raining.
What else?
Raining.
So you can also see his lack of being comfortable in this situation. He's very uncomfortable there. Here he is 6 months later, and you can see that he takes over the assessment from the assessor.
What about this?
They're cooking. And getting the plates ready. And they're getting the spoons ready and the forks.
Anything else? Oh, hold on. Okay. What about that?
They're going on vacation.
Okay.
So you can see his demeanor has changed entirely. And then the question is just how good can these kids get? So this is a story of a girl who was diagnosed when she was 2.5 years old. She received standard care until she was 8 years old. Made minimal improvements. She had great problems with social interactions and only had a few words by that time. And she also had a great number of idiosyncratic behaviors. Here she is at her brother's birthday. She was 4.5 years old here. And you can see her lack of engagement, poor attention, and no language. She's on the right.
Happy birthday to you. Happy birthday to you. Happy birthday, dear Ailey. Happy birthday to you.
Okay, so she stopped this therapy when she was 9.5 years old. Here she is at the age of 16 giving a TED Talk.
But then I decided enough was enough. I don't want to be a spectator anymore. I had to jump in the game and be a player. I adopted a new motto. It's called YOLO. You only live once.
So in the fall, she's off to one of the top colleges in America. It's amazing how far she's come. Okay, so the advantages of this treatment is that it's highly effective, much more effective than anything out there. And what's really interesting is that you don't need any expertise. We give the parents a kit, some instructions, we contacted them every 2 weeks, and that's all it took to do this at home. And because it was done by the parents at home, the expense was negligible. And indeed, one of the parents of these children has set up a website that will lead you through this kind of therapy anywhere in the world. So it's accessible now to everyone at minimal cost. It also extends the age for treatment. That is, With any of the intensive behavioral therapies, they are only effective until about 3 years old. In America, at least, the median age at which autism is diagnosed is 5 years old. So this really extends it. And in fact, we see a great deal of efficacy for children who are in their teens, something that's unheard of with current technologies. And finally, it deals effectively with a wide range of symptoms. Okay, so having seen this data, would you support the use of sensory enrichment to benefit the development of healthy infants as well as infants with neurological difficulties? 1, no. 2, yes. And 3, we need more evidence. Go. Okay. Very good. All right. And finally, I'd like to thank you for your attention.
Thank you very much for that excellent start to this session. So now, without further ado, it gives me great pleasure to introduce our second speaker, which is Professor Martha Pelaez from the University of Miami.
My name is Marta Pelaez, and I have done work in collaboration with Dr. Tiffany Field from the Touch Research Institute, and most of the studies that I will be reporting, the summaries, come from the research that has been done at that institute in Miami, Florida. I would like to start with the question and see how you feel about this. Touch is one of the baby's most advanced senses at birth. Even premature babies that are born early as 25 weeks are aware of being touched very early on. Well, how do you think does baby's sense of touch develop? From the head to toe? From the hands up the arms to the center? Or uniformly? Let's see. And the answer is 1, from head to toe. Let me summarize some of the findings that we have obtained in several studies. Most of you know that it's a very old form of therapy, infant massage. It dates back to China, to Egypt, to India. And what the research has done is really concentrate on different populations. So we will have the studies done with preemies, studies done with infants, adolescents, adults, and even the elderly when they give massage. One of the main findings is enhanced growth in the preterm infants. I'm going to talk a little bit more about this. It's a very interesting research in terms of the growth that we have obtained with the preemies. We also found decreased autoimmune problems like in pulmonary function in children with asthma and improved metabolic markers in diabetes. In general, the immune function of depressed mothers, teenage adolescents, has noted to be increased. Actually, the natural cells, killer cells in the adolescents with HIV was improved in one of the studies. We have put the references here of the journal articles in case some of you want to go back and review this literature. In the preterms, one of the findings I'm going to talk about it is the alertness and the performance, the enhanced EEG patterns in the preterms after massage intervention. And in my own area of research, the one I concentrate, we have found a lot of positive behaviors in the infant as a result of the mother-infant interactions when we train the caregivers about how to respond during the interactions with their mothers and the caregivers. And that I mean social behaviors like smiling and vocalizing, and specifically eye contact responses. The question then is, I'm sure for all of you, why? Why is it that these sensory modalities have an effect, a strong effect in human beings. And one of the possible mechanisms of action that has been reported in several papers has been the pressure in the receptors activates and increases the serotonin level. Also, the dopamine levels have been noted. Concurrently with this, we have a reduction in the cortisol levels, and as all of you know, the cortisol is the stress hormone. So we can induce mood, if you wish, by providing massage. And that happens, the mechanism also seems to be active in the infants. Going further into the why question, possible mediating roles are the vagal activity. And I say possible because all of these mechanisms, even though they have been investigated, the point is that they need to be reevaluated constantly to have validity. So stimulation of pressure receptors using moderate pressure through massage may increase the vagal activity, the vagal nerve in the brainstem. And what happens is you have, in turn, a reduction of the cortisol levels. That's one. There are concurrent mechanisms. Of course, you have gastric motility during the massage therapy. And what that means is the food absorption of the baby, it's a better, which in turn makes the babies gain weight. Well, let's get now to, after we speculated in the mechanisms of the benefits of infant massage to healthy full-term infants. In one study, there are many, many studies, but I will just summarize one. 104 full-term newborns were randomly assigned to receive either moderate pressure massage or light pressure massage. And the mothers were taught how to provide the massage once a day, routinely, before bedtime. And what the researchers did, what we did is we measured the weight, the length, and the head circumference, as well as use the Brazelton. I don't know how many of you are familiar with the Brazelton neonatal assessment scale, but it's a scale that measures 20 neurological reflexes, and it gives you an indication of how the baby is reacting. Reflexes, and also it's a very robust scale. Let me get to the results. What you find is that with moderate, as compared to light pressure, which can be also aversive sometimes, the moderate pressure significantly increases the weight and the length from birth to 1 month. In other words, from birth to 1 month, when you give massage daily, you get, in the Brazelton scale, you get a better baby's orientation, and also their suppressed behaviors, as measured by the depression scale, get better. So you have babies who will smile more and have more eye contact, as well as more vocalizations. And overall, their sleep patterns, which I'm sure some of you will be interested in, there's a lot of fascinating research in sleep patterns, will also improve the sleep-wake behavior. Jody Mandel is here, and she's done a lot of terrific work in that area. Further studies suggest, therefore, that the benefits, many studies, the benefits of massage also in healthy infants, but also in preterm babies. Among the findings still on health full-term babies, we find the reduced colic, the enhanced adjustment via the circadian rhythm to nocturnal periods. This is being also measured. And in general, better suitability. That means you can calm the baby as when they cry more easily after, babies that have colicky and they're not so easy to soothe can benefit from massage therapy. And in case of vulnerable infants, many of you know, and as Pandora is going to be talking about the Kangaroo benefits, touch in many ways is beneficial when we are in a day-to-day interaction with the baby, changing the diaper, picking them up. These are babies that were born prematurely. And in general, we know that the massage helps their immune function. They helps them. I'm repeating myself, but because the point I want to come across is their weight gain and how many of their even behavioral repertoires improve. For example, sucking response, which is so critical, and as well as the physiological responses like rate variability becomes more stable. And one important finding is that the reduced duration of hospital stay, which is very costly, and it puts the infants at the risk of late onset neonatal sepsis, and this has been documented. The early massage can be administered, of course, at home or in the natural birth setting, as well as in the hospital. Here in the neonatal intensive care unit can be controversial because in some hospitals, like for example in the United States, some hospitals have already adopted massage as the therapy that is widely used, whereas some other hospitals in the neonatal intensive care unit are still tidying up the protocol to see if they accept that at a particular weight. Like if you have a baby that is born under 3 pounds, they might not let you massage yet the baby, the nurses, to preserve that caloric intake. Baby Lev is a case that I want to present, only one case to make it more amenable, but it's at birth. She was 35 weeks gestation age, 4 pounds, 13 ounces, 19 centimeters in length, and very short hospital stay. Actually, the mother didn't want to stay in the hospital, so she wanted to rush back home to be able to do the massage. And she received daily massage intervention at home for many months, up to now. I mean, she's 1 year old now, and she's been receiving daily massage. So here she is. Even though it was a preemie, was fully alert. But the interesting thing is that, and here's what I want to make my contribution, if at all, is that what happens during that massage? What is the mother actually doing? How she or he, the parent, or the caregiver, responds to the infant's cues, to the infant eye contact, to the infant smile, to the infant vocalization. I think that is important. I have report studies that I published on motherly speech and what mothers do during these interactions. And what I want to show you here in Spanish.
¿Te puedo dar masaje en los brazos? Ok,
empezamos
con el brazo derecho. Con la axila,
Recommend they sing.
Suavecito, pero no muy suave. And twist and turn, and twist and turn, and twist and turn, and all the way to the fingers. And stop.
You can see the mother. The mother is instructed to vocalize back to the infant, and that's what I do in some of the research. You instruct mothers vocalize back while you're touching, using the powerful effects of touch, as Dr. Leon just emphasized. The case of Lev, after 8 weeks, is doing great, making eye contact,
Te vamos a dar un masaje.
cognitively well developed.
Tita.
Trying to imitate.
¿Qué? Qué linda esa bebesota. Le encantan los masajes, ¿verdad, Lev? ¿Y que sí? Que sí. Dile hola, Abby, a todos. Eso.
So the first modes of communication emerge, and this is a great opportunity to strengthen them, the vocal sounds during the massage. So I have a question for you. Psychologists have found that young babies can recognize their mothers from their voice, from a tape recording of only one syllable. So after how many days do you think, after how many days of life, after birth, does this develop? 1 day, 2 days, 3 days, 1 week. Please use your... Let's see what answer you got. Most everybody said 1 day. Very close, it's 2 days. All right. Actually, the research by Tony De Casper and Melanie Spence and some others have shown a lot of voice recognition in utero. When the mothers are pregnant, they read to their babies, and so the babies recognize the mother's voice. There's a lot of empirical evidence on that area. And lastly, I want to talk about the massage in fathers. The fathers, compared to fathers who provided no massage, when fathers provided and they were trained, the results show more positive interactions with their infants. As rated by the scales, the fathers improve themselves, their expressiveness. They enjoy more the relationship, their interactions with their infants. They accept them more, and they show more responsivity to their infants. Also, they increase their playing time and their feeding time. So overall, the father's caregiving situation was improved after training them on how to provide the massage. My last research slide. I wanted to filter this in because it has to do with a line of research that I really feel very passionate about, and it's postnatal depression. I know that not every culture shows, not every mother shows postnatal depression, but it's a widely documented phenomenon. And what we have done is several studies, Dr. Phil and I, where we have looked at the depressed mother's behavior versus the non-depressed, and in how they interact during these interactions with their infant, in the way they touch them, in the way they carry them, in the way they talk to them. And we know that the behaviors are suppressed from the research. So what we did is, here's the key, we instructed them to provide touch during their interactions, even though their auditory and their vocal and visual gesticulations, their emotional expressions were suppressed. In other words, what we are finding is that mothers that are depressed can reduce their negative effects of their flat affectivity and their typical unresponsiveness by touching their infants. So touch stimulation can compensate for the lack of auditory and visual and olfactory. We didn't test olfactory, but we tested auditory and visual stimulation, and we find that it buffers that. So I think it's very good also for the mothers, and it suggests that we should continue doing more research on this. And I want to conclude by saying the massage and touch benefit babies, healthy babies, babies that are vulnerable, that are preterm, but also helps the parents, the caregivers, the midwife, the mothers, the fathers in general. So I encourage you to give a good massage to infants when you have a chance, and thank you so much for your participation.
We're going to move on swiftly to our final speaker in this session, who's Dr. Pandora Hartman, and she's going to talk to us more about some of the practicalities of incorporating touch within our daily routines.
I see some of you falling asleep. Good afternoon. Anything after lunch is always dreadful, isn't it? As interested as you are, you just kind of drag, and these conferences don't leave us much time for anything. Well, today, hopefully, you're going to come away from this a little bit energized as I talk to you a wee bit about routines that incorporate touch into our daily care and practice. Midwives are high-touch, low-tech. This is probably familiar to many of you, as is a quotation from the text. In fact, it is arguable that a midwife's hands were the first and the only things that she had. Many years ago, before the technocratic model came in with all of the machines that go bing in the night. Touch in midwifery. When we think about the historical context, we think of the holistic practice that integrates many aspects of the care, and even the blessing of hand ceremony, which is near and dear to many of us in many continents across the way. In fact, if you think about your hands, right? Think about the strength that's needed to wrestle that shoulder dystocia out. It's not gentle hands that we need to have at that point, huh? It's not. Or the new appreciation that you begin to have for your hands when you had a paper cut that you didn't know about, and then you have to wash with alcohol-based hand gel, and you're like, because everything's stinging. Makes you think about your hands in a whole new way. I am sure that every midwife in the room has done this countless times. Yeah, and our backs tell the story later, and your knees, and as much as we try and pay attention to good body mechanics. Because this is incorporating the touch that is a part, an essential part of midwifery care. In fact, touch is so core to who we are and what we do that in every birth that you've attended, I'm betting that you've touched somebody. So here's a question for you. How many births have you attended? None. I'm not a midwife. 2, 1 to 100. 3, 101 to 500. 4, 501 to 1,000. 5, 1,001 to 5,000. 6, greater than 5,000. Or, like me, throughout the delivery log after I had 17 babies in 24 hours. Pretty close. So it seems that the bulk of us are in the 1,001 to 5,000 range of babies. That's a lot of lives that you've touched. A lot of moms, a lot of babies. Touch is essential. When we look at the ICM competencies that even guide our practice, you'll see that core concepts of touch are thoroughly integrated into several of the competencies, including this one, Competency 5. When we look at the provision of high-quality, culturally sensitive care, because touch definitely does have some cultural connotations as to where is appropriate to touch, how is appropriate to touch. And we look at both the basic knowledge and the skills that are required of us to make this a part of an everyday practice reality in our promotion of healthy parenting, bonding relationships, and the exclusive breastfeeding. We can also look at Competency 6, which speaks to comprehensive care for newborns up to 2 months of age. Again, looking at our knowledge, our attitude, and our skills, and looking at the advantages of some practices that we know are beneficial for both mothers and babies in terms of growth, development, and I think my colleague, Professor Leon, showing the extreme changes that can happen with just a little touch. Beyond that, it's not just the ICM, but the International Mother, Baby, Childbirth Initiative. When you look at their principles as some of the organizations that guide us, these are the specific steps that integrate aspects of touch, 2, 5, 7, and 9, which speak to things such as respect, culturally appropriate care, evidence-based practices to pull us together as midwives who are striving for a healthier world. Early skin-to-skin contact has some proven benefits. When we look at the Cochrane database as one of our gold standards for care, we can see the ultimate benefits, that decreased crying and increased breastfeeding duration and interaction of the mother-infant diet. Also, this has midwife benefit because that decreased crying means decreased calls to you in the middle of the night because the mom's not quite sure what's going on. So we know that the evidence supports the skin-to-skin contact early, uninterrupted in many trials. We see that mom has benefits from skin-to-skin contact too. And I like to think of this, instead of us getting on the cycle of intervention that leads to more technological use of birth, we're looking at the wheel of low-key interventions in terms of reduction of postpartum bleeding, which is still one of our chief causes of loss in the developing world, to a shorter third stage, to increases in the love hormone, which is going to help with the bonding and the family transition, to decrease cortisol levels, and an overall greater satisfaction with the birth experience, which definitely helps us when it comes to midwifery advocacy issues, because midwives are not always well thought of. So just think, skin-to-skin contact, you've helped the profession by advocating that midwives are really okay. And that ultimate confidence in a woman's ability to handle a newborn. The earlier we start, the better it's going to be for everyone. Skin care in action. This is one of my home births from about 10 years ago. We were getting mom settled and turned around, and there he was breastfeeding. I think that was the ultimate evidence of what we do has a long-reaching impact for many people. It was darling. If we look at some of the evidence-based practices that are integrated in touch, we look at the concept of kangaroo mother care. I'm sure that many of you have heard about this, but just in a quick review, as we look at the benefits of kangaroo care, they thought, okay, well, this is just something that applies to the developing world, small babies, where the realities are we have no incubators, or we have such limited NICU bed space that there's no way to keep these babies warm, these little tiny babies warm. So the kangaroo care with the mother's bodies, the warmth of the mother's bodies, providing increased breastfeeding, increased milk volume, and ultimately the decreased neonatal morbidity and mortality. Something simple, easy to implement, and we know that it's not just for the developing world. Kangaroo care is easy to implement with these touch and these hands and these teaching. You see here, this is one of the kangaroo mother care rooms at one of our district hospitals, whereby the women actually teach each other how to tie on the babies. And they're helping each other and feeding each other and making a difference. So in human resource constraints, we use the moms to teach each other how to do kangaroo care for the ultimate empowerment. So when we think about this, here's another question to test you out. What estimated proportion of preterm deaths could be prevented with interventions such as kangaroo care? 4/5, 3/4, 1/2, 1/3. What are your thoughts? Key in, we're almost there. Let's see. And the 1/2 has it. The reality is 3/4. That's a lot of babies, huh? By something so simple as a midwife using her hands and encouraging. Okay, so at the end of the day, what does any of this really mean? And why don't we do it more? Some would even say that there's a relationship between the more technology that we have in the room, be it the delivery room or the clinic room, that the less touch we actually do to the patients. So I want to make you think about something and walk away with a new appreciation for a midwife's touch points, because there are several along our continuum. Let's look at antenatally, our antenatal touch point, whereby from the minute you're lifting her shirt, her dress, to measure that belly, are we just taking a tape measure and going, okay, 32, see you in 2 weeks, see you for your next focused visit? Or are we taking that time and massaging and talking and playing with the baby and saying, oh, there's the pieces? Or do we get so bogged down with the realities of a busy clinical practice that we forget that touch is there? Or another midwife touch point in labor, whether we're listening with a Pinard or using sacral pressure to try and give her some relief. Another key touch point, what about crowning? Who's played with the curls as a baby come out? Or, you know, the more aggressive touch when you're doing some really good scalp stimulation because you need those heart tones to go out and get that baby out really fast? All different aspects of touch. And once our hearts are better and that baby is out and that first hug, the baby going right up to the mom's chest and making sure that it's staying there. And delaying some of those routine procedures, the temperature, the weight, all that. The baby's weight's not going to change. I used to say all the time, it's going to be the same in half an hour. What's the hurry? But we know, too, that if we don't draw the attention to that, these are the touch points in the first impressionable hours that get forgotten about. Or breastfeeding. A whole new appreciation for this. This picture was taken in a family planning session. There were 60 moms. Everybody was pretty much nursing or breastfeeding. The boobs were just there. I thought, this is great. This is how it should be, a community of touch. Babies just passed along. There wasn't all that funny stuff about the breast. It just was. It's a part of what we do. Or ultimately, touch in our mother-infant dyad. We're quite proud of this pair. You see our little impango were quite tiny, tiny, but we managed to get both of them onto the breast and nursing despite the tubes. Beautiful. It's possible. But we have to be able to think beyond the possibilities and think about the importance of touch in your hands. The mother-infant dyad and touch continues. Question, rates of twin births vary. What country has the most? Cameroon, Ivory Coast, Burkina Faso, or Benin? Okay, pretty tight between the Ivory Coast and Burkina. Benin has it. Woo! I think that we have some Benin midwives sitting here in the front here. Touch points, as we continue to think about the routines where a mother can be taught these routines to help promote the health and hygiene in terms of skin and sleep and bonding for the baby. Skincare is healthcare. It's not a correlation that we rapidly make, but even when we go to the often cited MDGs, we can look at the fourth MDG that skin health is good hygiene, and that basic skincare facilitated by touch is integral to overall human health, and that it's vitally important for infants. We know, too, that the newborn skin needs extra protection because it's not fully developed in terms of structure, composition, and function, and that it can be more prone to dryness during the first months of life as compared to adults and later infancy. It's why we like to bury our noses in the folds and rolls of a baby because they're so soft and they smell nice. Knowing that there's less natural, skin is thinner, so there has less natural moisturizing factor than adult skin. Oil tends to be a controversial issue, but what the research also tells us is that natural oils that are not specifically formulated for baby skin may be active. And the take-home message out of this, I think, is the third bullet point, that looks at routine application not harming a healthy infant skin, but also raising the awareness of what we're using. Particular olive oil is one of the oils that's often talked about in terms of recommendations not being appropriate. We know that bedtime routines can improve the baby's sleep. Okay. We talk here about warm bath and massage as routines that'll help with the mom, but knowing too that any routine for a baby is going to help both the mother and infant dyad with touch, with massage, with the calming. We use a bath as a calming time, and that we know that bedtime routines result in significant increased sleep, which makes both moms and babies happy at the end of the day, and an ultimate better maternal mood. Routines that enhance bonding. Well, when we think about this, we talk about increased tactile stimulation between mom and baby, whether it's tying the baby on the back and giving the baby a wee bit of a massage, or that routine massage that is incorporated into every diaper change, every interaction with mom and baby. Hands, touch, the midwife's touch points are essential and key. The words of Steve Jobs remind us that women who are crazy enough to think they can change the world are usually the ones that they are. So I want to end with you thinking about a world that is ultimately changed by the midwife's touch and all the good that we can do with these two little things that are key to us. So at the end of the day, we want to know what you think. Has this presentation inspired you to encourage new moms to consciously use touch as a part of their routine care? No, I need more hard evidence. No, I think moms do this enough instinctively. Or yes, I think that this is beneficial and should be encouraged. And the opinion poll says we did it. Mora koze chane. Best wishes, good luck, and happy touching.
So the first question is to Professor Leon. Can you commence therapy with children who are adverse to touch?
So it's not unusual for children to be adverse to either odors or touch, but it turns out that when you give them the combination of odor and touch, it calms them down and allows them to accept either one of them. We also find that if in some cases the children don't like being touched on their back, there's some place on their body that they're comfortable receiving it. So it may be their arm, it may be their leg, but some place will allow them to accept this kind of therapy.
Thank you. And then we have a question for Professor Palaise. Is it possible to overstimulate an infant, especially a newborn premature infant?
Yes, I think it's possible, and I think that's why we need to pay attention to the signals that the infant is giving us of the stress by looking at their grimacing and their protest or their activity levels in their body. So I think we need to be very careful and just follow the signals. The baby will tell us how much they prefer and how much is what they're liking.
Okay, thank you for that response. And then we have another one here for Professor Leon. What is sensitive enrichment therapy in simple words?
In simple words, we just try to give the children sensory stimulation of all kinds. So we give them warmth and cool, we give them touch, we give them massage, we give them odors, we give them visual stimuli. We don't know that any one of the 36 exercises that we give are critical, but we just try to stimulate all of their senses. And we try to have novelty in what they're doing so that it's a game, it's new, and it keeps their interest.
We've got a question as well for Pandora. I think you have the question there, have you? Could you? Could you read the question out for me?
The question was about the thoughts with regards to flicking the baby's sole of the feet to suck more when sleeping. While this does work, the evaluation has to be made about whether this is an infant that we're concerned about in terms of ultimate growth and weight gain, whether it's a poor sucking pattern. It's not a methodology that has to be employed at all times for every case if you do have a baby that's feeding and growing well.
Thank you. So I'd just like to thank all our speakers for such excellent presentations and lots of food for thought.